Hello everyone, this is Dr. Govind Rai Garg. In this video, we will discuss the kinetics of drug elimination, or if you talk in simple terms, we will discuss some formulas, some mathematical operations, some calculations in this video. Okay, so what we are expecting in this video, you should know about rate of elimination and clearance, then formulas of half-life, steady state concept, which is very important, therapeutic drug monitoring, another important thing, and the last one will be order of kinetics, drugs following zero order and first order kinetics. Okay, so we will start with the basic things. We already discussed some formulas earlier, like we discussed the formula of volume of distribution, formula of loading dose, and formula of maintenance dose. A quick recap: volume of distribution is amount of drug given divided by C0. Loading dose is equal to Vd into target plasma concentration. And this is what that concentration which we are saying is steady state plasma concentration. And maintenance dose is clearance multiplied by target plasma concentration. These formulas we have already discussed. So now we will discuss some more formulas. And the first one among them is rate of elimination. Rate of elimination, which is commonly represented as R. So if you recall, what do you mean by elimination? Discussed elimination is termination of action of a drug. It may be by metabolism, maybe by excretion. It is termination of action of a drug, finishing the action. Okay, so at what rate the action is finished is rate of elimination. Suppose 100 milligram of drug, it become inactive in 10 hours. So it will be simple. Divide the amount of drug becoming inactive divided by how much time it takes. So rate of elimination of this drug will be 10 milligram per hour. Okay. So rate of elimination is easy to calculate. How much drug become inactive divided by how much time it takes. Now suppose we say rate of elimination of a drug is 100 milligram per hour. So what information does it convey? Whether the drug is short acting or long acting, action will run for long period or it will finish quickly? We cannot say, because we only get the information that in 1 hour 100 milligram will be eliminated. Okay, but we do not know how much is in the plasma. If 200 milligram is the plasma concentration and out of that 100 is eliminated, that means half is eliminated. Okay? If plasma concentration is 1000 and then 100 is eliminated, that means in 1 hour only 10% is eliminated. So rate of elimination is not a complete parameter. It is an incomplete parameter. We must know the plasma concentration to utilize it effectively. Okay, so instead of using rate of elimination, we use another formula which is called as clearance. Clearance is written as CL. Clearance is simply rate of elimination divided by plasma concentration. So rate of elimination was telling that in how much time, how much will be eliminated. But clearance will be telling that in how much time, how much will be eliminated from how much also. Clear? So clearance will be telling that 100 milligram per hour is eliminated from 200 milligram. Okay. So this is a complete parameter. If clearance of a drug is high, then drug will become half quickly, or we can say drug will be eliminated quickly, so it will be short acting. If clearance is low, the drug's action will be prolonged. Okay, so clearance is the complete parameter. We commonly use clearance in further discussions. Okay? Now if you remember, in biochemistry you must have studied, in physiology you must have studied another formula of clearance called as UV/P. Remember, U is urine concentration, P is plasma concentration of a substance, V is rate of urine flow. Now my question is, why we use different formulas of same thing in different subjects? In physiology we are using UV/P, in pharma we were using rate by plasma concentration. The difference is, you can see here the word is U. In physio we were talking about renal clearance only clearance through kidney. So when we want to know how much kidney is clearing, then it will be UV/P. But in pharma, we are concerned with whole body. So total body clearance is told by rate of elimination divided by plasma concentration. Remember, rate of elimination contains elimination, and elimination means metabolism plus excretion. So that means we are also talking about other things here. Okay, so renal clearance is UV/P and total body clearance is rate by plasma concentration. In pharmacology, we often use this formula. Okay? Now, understanding one more important thing. So, we'll try to first make it simple. Suppose this is your liver. The artery is bringing the blood toward the liver. Along with the blood, the drug will also come back. Then the veins will go out from the liver. Now, suppose the artery is carrying 100 milligram of a drug, or we can say 100 molecules of a drug. Okay. Then 20 milligram it is removed by liver, so liver retains it, and rest of the 80 molecules or 80 milligram has been returned via the veins. Okay. So what we can say, the extraction ratio, hepatic extraction ratio, name says how much drug has been extracted by the organ. So in this case liver, so it is hepatic extraction ratio. So how much is extracted by liver? Out of 100 milligram which is entering and 80 milligram which is leaving, so 20 milligram is extracted. Okay. But 20 milligram is extracted because it is a ratio. It is a ratio between how much is extracted from how much is coming. So 100 was coming. So hepatic extraction ratio will be 100 minus 80 by 100. That means 0.20, or we can say 20%. You understand? So hepatic extraction ratio or extraction ratio by any organ is when a drug enter that organ via the blood, then it will go out. So how much drug is left in that organ divided by how much was entering in that organ. Clear? So if you see the formula, it will be concentration of drug in the arteries which enter the liver minus concentration of drug which is present in the veins leaving that organ, and divided by concentration of drug in the arteries. That is extraction ratio, hepatic extraction ratio in this case. Similarly, it can be extraction ratio by the kidney, by the brain, by any organ. Okay, so we calculate the extraction ratio first, and if we multiply this extraction ratio by the blood flow to that organ, that will become clearance. So clearance, but here the clearance will be hepatic clearance. So if we see hepatic extraction ratio multiplied by blood flow to the organ, that means liver, it will become hepatic clearance. So we can calculate the clearance of any organ. And when we add all these clearance, it will become total body clearance. And the formula of total body clearance is rate of elimination divided by plasma concentration. So you need to concentrate mainly on this thing. Okay. Now moving to one very, very important parameter which is called as half-life. Half-life, also written as T half. As the name tells, it is the time. Life means time. It is the time in which plasma concentration become half. In how much time plasma concentration become 50%, that is called half-life. For majority of the drugs, half-life is constant. That means same time it take from 200 to become 100, and same time it will take from 10 to 5. Half-life is constant for most of the drugs. So for such drugs, when half-life is constant, the question is asked, very simple question is asked. First we will try to understand the simple thing. Suppose initial concentration is 100 and it become 50. The time is called as half-life. Suppose it is 1 hour. So in the next hour, it will become 25. In next hour, it will become 12.5. In next hour, it will become 6.25, and so on. So in same time, it will keep on becoming half. Okay. So for such a drug, the simple question which is asked, like question is asked, a drug has half-life of 6 hours. They may give anything, 6 hours, 8 hours, 12 hours. Half-life of a drug is 6 hours. After 1 day, after 1 day, 1 day means 24 hours. After 1 day, how much drug is left? So read carefully. The question is, after 1 day, how much drug is left? So it's very simple to calculate. We have half-life of 6 hours. 1 day means 24 hours. That means there will be total 4 half-lives. 24 by 6, 6, 12, 18, 24. Clear? So if we say first half-life is 6 hours, then 6 plus 6, 12, plus 6, 18, plus 6, 24. So how much drug is left after 24 hours? So after 6 hours, 50 is left. After 12, 25 is left. After 18, 12.5 is left. And after 24, 6.25 is left out of 100. So how much is left? The answer will be 6.25%. Out of 100, 6.25 is left. Okay. But read the question carefully. If we change the statement slightly, the answer will change. Like another question asked is, a drug has half-life of 6 hours. After 1 day, how much drug is eliminated? So second question is, how much drug is eliminated from the body? Remember, now it is not asking how much is left. Now they are asking how much has been eliminated from the body. So it's very easy. We discussed that 6.25% is left. That means rest is eliminated. So when we want to calculate eliminated, answer will be 100 minus the left. So in this case, the answer will be 93.75%. Is it clear? So that is question, simple question on the half-life. Now how to calculate half-life? So if you see half-life, what should be the relationship between half-life and clearance of a drug? Tell me logically. If a drug has high clearance, what should happen to half-life? If clearance is high means it will become half quickly. That means half-life will be lesser. So we can safely say half-life is inversely proportional to clearance. Logical. Now what is the relationship between half-life and volume of distribution? If volume of distribution is high, means most of the drug is in the tissues, very less is in the plasma, and the drug which is in the tissues will act as a storage site. So the drug which is in the plasma, that will be metabolized, but again it will come from the tissues. So it will keep on working for a longer time. So what will happen to half-life? It will be longer. So usually when volume of distribution is high, half-life is high. Clear? So if we combine the two, we can say that half-life is proportional to volume of distribution divided by clearance. Logic? And if we make it equal, we want to make it formula, then we will write a constant of proportionality, and the value of that constant is 0.693. So the formula of half-life is 0.693 into Vd by clearance. 0.693 into Bd by clearance is half-life. Now what is important? This clearance by Bd, clearance by volume of distribution, it is known as elimination rate constant. Remember, this k is not same, this is general any constant what we write. So this k is elimination rate constant. So elimination rate constant, the formula of that is clearance upon volume of distribution. So if we put this formula here, the formula of half-life will become 0.693 by k. It's even very easy. So sometimes they give the value of elimination rate constant and ask you to calculate the half-life. So simple 0.693 divided by k. Okay. So two formulas of half-life you need to remember: 0.693 into Vd by clearance or 0.693 by k. Okay. Now coming to very important thing, what is the clinical importance of half-life? If half-life of a drug is high or half-life is low, what does it mean? So simply meaning is, if half-life is more means the drug will be working for a longer period. Half-life is less means drug will be working for a shorter period. That is the simple thing. But now important thing is, can you tell the dose of a drug from half-life? Can you tell the dose of a drug from half-life? The answer is no. Why no? Because what is the unit of half-life? Unit of half-life is unit of time. It may be in seconds, minutes, hours, days. The unit of half-life is in the unit of time. So have you ever heard that the dose of this drug is 6 hours? Obviously not. So half-life can tell only that thing which can be measured in unit of time. So half-life cannot tell the dose of a drug. Logically, suppose two drugs have same half-lives, does it mean that they will have same doses? Obviously not. So dose depend upon property of a drug, how potent it is. So half-life do not determine the dose of a drug. Then what does half-life tell? It tell the dosing interval. Half-life do not tell about dose, but it tell about dosing interval. So half-life cannot tell that we need to give 10 milligram or 100 milligram, but it can tell that we need to give twice a day or thrice a day or 4 times a day. Okay, so half-life tell the dosing interval. So dosing interval also known as frequency. If we say dosing interval is 12 hours, so that means we have to give twice a day. So 12 hours is dosing interval, twice a day is frequency. So half-life tells about dosing interval or frequency. Very important thing is do not tell about dose of a drug. Okay, so that is important about half-life. Now related to half-life and other parameters, we will move to a very important concept known as steady state concept. Now first we'll try to understand something. Like we give a drug on a daily basis. Repeatedly we are giving a drug. Suppose we are giving 100 milligram drug after every half-life. Suppose half-life of a drug is 12 hours. So we are giving 100 milligram every 12 hours. That means twice a day. So what we will expect when we give 100 milligram initially. Suppose initial concentration was 0. It was 0 here. When we give 100 milligram, the plasma concentration become high. We can assume 100 molecules we have given, plasma concentration become this. But with half-life, because we will repeat after 12 hours, so with half-life, it will become half. Then we give 100 again. So it will again increase. So we had given 100 earlier. It has reached the 50 mol mark. Then we give 100 more, it become 150. Then again, it will become half in half-life. So it will become 75. So after this, we will give 100 more. So it will become 175. Then with half-life, it will become lesser. Again, 87.5. Then again we give 100, it become 187.5. Again half, again 100, again half. So what you will note is initially when we give a dose, the plasma concentration increase. But after some time, it will become fixed. Become fixed. We take the average concentration, it become fixed. So this average concentration, this is known as steady state plasma concentration. So we have achieved a steady state, means although we are still giving the drug, but the concentration do not vary much. So you can understand in this manner. Initially when we give the first dose, the rate of administration we have kept constant. That means we are giving 100 milligram every half-life. So we have kept this constant. When the drug was not in the blood, plasma concentration was 0. So there will be no excretion from the plasma, no elimination from the plasma. So rate of elimination is 0. Rate of administration is this, rate of elimination is 0. So when we keep on giving, the drug will start staying in the plasma. So some of them that will be eliminated also. So rate of administration we have kept constant, but rate of elimination was 0 initial, but it keep on increasing. After some time, it will become equal. So that means rate of administration is equal to rate of elimination. That means how much drug we have given in 12 hours, same amount will be eliminated in 12 hours. So the net amount in the body will become constant. So that state is known as steady state. So what is steady state? It is a state where rate of administration of a drug is equal to rate of elimination of a drug, or in simple language we can say plasma concentration is stable. It is steady. So that state is known as steady state plasma concentration. You understand the concept? So the formulas which we discussed of loading dose and maintenance dose, and there we discussed target plasma concentration. It is this concentration when it reaches the steady state, when it becomes stable. So we always measure the concentration when it becomes stable. Okay. Now, 3 important points to be noted from steady state plasma concentration concept is: number 1, when will achieve this steady state plasma concentration? After how much time we will achieve this? Remember, this is achieved usually between 4 to 5 half lives. 4 to 5 half lives are taken to become steady. Okay? So if half life of a drug is 2 hours, it will become steady in around 10 hours. But if half life of a drug is 5 hours, it will take around 25 hours, around 1 day. If half-life of a drug is 24 hours, it will take 5 days. So steady state plasma concentration, when it will be achieved in 4 to 5 half-lives. So when to reach steady state, it is dependent upon half-life of a drug. Okay. Now second question is, how much steady state will be achieved? That means the steady state concentration which we are achieving here, how much this concentration will be, whether it will be 100, 200, 500, 1000. So in what thing it will depend? Obviously it will depend upon dosing rate. How much dose and how much frequently we are giving, total rate per unit time, how much dose we are giving, it will depend upon that. If we are giving more per unit time, more will be achieved. If less, less will be achieved. And third, when it reach a steady state, the variation between peak and trough. So this variation between peak and trough, this will depend upon which factor. So we can try to understand the concept. Like if we are giving after every half life, the plasma concentration is varying like this. So in 5 half lives, it has become almost stable. So if we take the average concentration, this is the steady state plasma concentration, average of this. Okay. So this is average, this is plus, this is minus. So this plus and minus, peak and trough, this difference will depend upon how frequently we are giving. Like if we suppose want to give 1000 milligram per day. So we have many options. The first option is we can give 1000 milligram once a day. So when we give 1000 milligram once a day, initial concentration will be very high. And after 1 day we are giving, so lot of drug metabolized, eliminated also. So this variation will be much higher. Again we give 1000, again lot will be metabolized. Okay. But on the other hand, we can also make it 1000 milligram per day by giving 250 milligram 4 times a day. 4 times a day. So we give 250 milligram 4 times a day. What we are doing is we are increasing the concentration slightly, then the decrease, then increase, then decrease, then increase, then decrease. So if you see that if we are giving more frequently, the line will remain same, average line will remain same, but the variation between peak and trough will decrease. Okay? And if we are giving continuous IV infusion, continuously the drug is going into the body, then this will be a single line which we have drawn here. Clear? So you can simply remember that how variation between peak and trough, it will depend upon the dosing frequency, how frequently we are giving. If we are giving total dose same, obviously. So 3 important MCQs to remember. How much steady state plasma concentration will be achieved, that depend upon dosing rate. When it will be achieved, it depend upon half-life. And what will be the variation between peak and trough, that will depend upon the frequency of administration. Okay, so steady state plasma concentration is very important concept. Okay. Now another concept related to this is therapeutic drug monitoring. Therapeutic drug monitoring, or in simple language known as TDM. Now before going to this concept, we will try to understand some basic thing. How we adjust the dose of a drug. Suppose a person comes to you with hypertension. You measure the blood pressure and the blood pressure of the person comes out to be 180 millimeter of mercury. And you want to reduce it to 120 millimeter of mercury. That means you want to reduce it by 60 millimeter of mercury. And for reducing the blood pressure, you give an antihypertensive drug. Suppose you give a drug A, which is an antihypertensive drug. The standard dose of this drug is suppose 10 milligram. So the person has come to you with hypertension. You give him 10 milligram of drug A. Now, how will you come to know whether this dose is enough or not? Whether you need to give 5 milligram or you need to give 20 milligram, how you will come to know? By checking the BP, obviously. So we will ask the person to take 10 milligram of drug A for a few days, come back, we again check the blood pressure. If the blood pressure is near 120, that means the dose is okay. If the blood pressure is still 170, 160, 140, that means the dose is lesser, we will increase the dose. But if the blood pressure become very low, suppose it reach 70, 60, that means the dose is high for this person, we reduce the dose. So that is the normal method of adjusting the dose of a drug. That means according to response. Like similarly for anti-diabetic drug, you want to control blood sugar, you give a drug, some particular dose, and ask the person to take for few days. Again measure the blood sugar. If it reach the target level, that means the dose is okay. If it do not reach, we will increase or decrease. So that is the normal method of adjusting the dose of any drug. But this is not practical everywhere. Like another person has come to you with seizure. Person has come to you, that person has developed seizure. Epilepsy is there. And for treatment of epilepsy, you give another drug, drug B. The standard of dose of this is suppose 100 milligram. So you give 100 milligram drug to this person. Now, how will you know that this dose is enough or not? Obviously, we will not wait that if the person develop another seizure, then we will increase the dose. Or we will not wait that some side effect should happen, then we will decrease the dose. So here the problem is we cannot monitor the response, because even without the drug, person may not develop seizure for few days. So when we are not able to measure the response, then how we adjust the dose of a drug? How do we adjust is we adjust according to plasma concentration of a drug. So we know that this drug will be effective if the plasma concentration is between 5 to 10 microgram per deciliter. So what we will do? The same thing we will do. We will ask the person to take drug B 100 milligram for few days. After that, we will call the person, but now we will check the plasma sample. We will take the blood sample and measure the plasma concentration. If it is between 5 to 10, means that dose is okay. So we will continue. If it is less than 5, we will increase the dose. If it is more than 10, we will decrease the dose. Okay? So this method of adjusting the dose of a drug, it is called as therapeutic drug monitoring. So therapeutic drug monitoring is adjustment of dose of a drug according to its plasma concentration. Okay. Now, if we are adjusting according to plasma concentration, that means we are doing the best thing, because the response is according to plasma concentration. So if we are doing best thing, then we should do TDM for every drug. But we do not do. Why we do not do TDM for every drug? The simplest reason is, for doing the TDM, we have to take the blood sample. And for taking the blood sample, we have to prick. When we can easily measure the blood pressure, why we will prick the person? Okay? So normally we will like to measure the response. So when we are not able to measure the response, only then we think of doing TDM. Otherwise, there is no point in doing TDM. Second thing, suppose we cannot measure the response, but we want to do TDM. We want to do TDM, but so first point we just discussed, when we cannot measure the response, only then we think of doing TDM. Okay. Second thing, after measuring the plasma concentration, we will have to check the plasma level, we have to check the concentration, and measurement of concentration requires sophisticated instrument, like we require HPLC, we require flame photometer. So these are very costly instruments. These are not available everywhere. The person who are sitting on these instruments, they are very expert, they are not available everywhere. So when we have to measure the plasma concentration, it will become very costly. Now suppose a person comes to you with hypertension, you measure the blood pressure, give him a drug, and ask him to come back after 7 days with 50,000 rupees. So person will never return. So this is practical problem. So it is very costly. Experienced persons are required, they are not available everywhere. So because of all these limitations, TDM is not the first choice, but it is the last choice. When we cannot adjust the dose by any other method, only then we look at TDM. So when we will do TDM? One, when we are not able to measure the response. When we can measure the response, we will never do TDM. So this is the important MCQ, for which drugs we will not do TDM, where we can easily measure the response. Like for any antihypertensive drug, we will never do TDM. For AC inhibitors, for beta blockers, we will never do TDM because we can easily measure the response. For anti-diabetic drugs, we will never do TDM. We can easily measure the blood sugar. So anti-diabetic drug like metformin, we will never do TDM. Third, for anticoagulants like warfarin, we can easily measure the prothrombin time. For heparin, we can measure the APTT. So there is no point of doing TDM. So remember, for these three type of drugs, we will never do TDM. Suppose we are not able to measure the response, but the drug is very, very safe. Very, very safe means the effect of the drug will start at 10 microgram per deciliter. There will be no side effect even if the plasma concentration reach very high, maybe till 1000 microgram per deciliter. Only the side effect will start after this. So when we give 100 milligram of a drug, the plasma concentration is near 10. Suppose when we give 100 milligram, plasma concentration come out to be near 10. In some person it may be 8, in some person it may be 12, it may be 15. So if it become less than 10, it will be in effect. But who has stopped us? We can always give 200 milligram. If we give 200 milligram, it will be near 20, maybe 15, maybe 25, maybe 30. So we all are safe. So if a drug is so much safe, then there is no need of doing TDM. If a drug is very, very safe, wide margin, then there is no need of doing TDM. Simply we will give high dose of a drug. So we will do TDM only when the margin of safety is less. That means less than 10 no effect, more than 20 toxicity. So this is known as therapeutic index. If the drug has narrow therapeutic index or narrow margin of the safety, only then we will do TDM. If therapeutic index is wide, then we will never do TDM. Okay, so example of this type of drug is penicillin. Penicillins have very wide therapeutic index. So for penicillins, we will never do TDM. No TDM for penicillins because it has very wide therapeutic index. But on the other hand, drugs with narrow therapeutic index, we have to do TDM. Okay? So you can remember some of the drugs which have narrow therapeutic index. You can remember them as a drug possessing very low therapeutic index. So from the mnemonic itself, you can remember these possess low therapeutic index. So the drugs are A for aminoglycosides, D for digoxin, P for phenytoin, V for valproate. In fact, most of the antiepileptic drugs. L for lithium, T for tricyclic antidepressants, and I for immunosuppressant drugs like cyclosporin and tacrolimus. So these are the drugs for which we commonly do TDM. So TDM is commonly done for drugs which have narrow therapeutic index. So you can remember as a drug possessing low therapeutic index. So aminoglycosides, which are antibiotics, digoxin, which is used in congestive heart failure, phenytoin and valproate are anti-epileptic drugs, lithium used for bipolar disorder, tricyclic antidepressants like imipramine, they are used in depression, and immunosuppressant like cyclosporin and tacrolimus, they require therapeutic drug monitoring. But the drugs like antihypertensives, antidiabetics, warfarin, penicillins, they do not require TDM. Okay? So this is second criteria where we will do TDM. Now third, suppose the drug is having narrow therapeutic index, that means we want between 10 and 20 only. But when we give 100 milligram of the drug, the plasma concentration comes out to be 15. So we give 100 milligram to one person, plasma concentration was 15. We give 100 milligram to second person, it was 15. We give 100 milligram to third person, it was 15. We give 100 milligram to 10, 20, 30, 100, 500 people. In every person, it comes to be 15. So if the drug has so much consistency, that means with giving a particular dose, always concentration is this, then there is no point doing TDM. So TDM will be done only when the drug show variations. That means by giving same 100 milligram, one person is getting 15, second person is getting 8, third person is getting 25. So we cannot know that our patient will get what concentration. So we will adjust by measuring the plasma concentration. Okay. So three criteria for doing TDM. Number one, the response should not be measurable. Number two, narrow therapeutic index. And number three, it should show variations. Okay. So that is important about the therapeutic drug monitoring. Okay. Now with all this, now we will move to the last topic here, which is called as order of kinetics. Drugs follow two type of kinetics. They may follow first order kinetics and they may follow zero order kinetics. And you can remember everything about them from the first letter of first order kinetics, that is F. The meaning is, in first order kinetics, fraction is constant. F means fraction is constant, whereas in zero order kinetics, amount is constant. Now, what do we mean by fraction is constant or amount is constant? Fraction is constant means in same time, same fraction will be eliminated. Same percentage will be eliminated. So we'll make it mathematically to understand. Suppose initial concentration of a drug was 100 and it become 50 in 1 hour or 1 day, some same unit. It become 50. So that means how much drug is eliminated? 50%. Fraction means percentage. So every hour 50% will be eliminated. That is in the first order kinetics. Like in next hour, how much will be eliminated? 25. Next hour 50% of 25, that means 12.5. Next hour 50% of 12.5, that means 6.25. So that means same time, same percentage is eliminated. It is first order kinetics. Okay. But on the other hand, in zero order kinetics, it is same amount, not percentage. Suppose it become 100 to 80 in 1 hour. How much is eliminated? 20, not 20%. Remember, had it been percent, it will be first order. But here it is amount, 20. So that means every hour, 20 will be eliminated. That means next hour from 80 to 60. Next hour from 60 to 40. Next hour from 40 to 20. And so on. So in case of first order kinetics, fraction is constant. In case of zero order kinetics, amount is constant. Okay. Now we will try to understand the difference in these based on the three formulas we just discussed. One formula is rate of elimination, second is clearance, and third is half-life. We'll try to see what is the difference in first order and zero order kinetics. Okay. So starting with the first thing, rate of elimination, we discussed how to measure rate of elimination. What is rate of elimination? How much drug is eliminated divided by how much time it takes. So if we calculate the rate of elimination at this point, how much drug is eliminated? 100 minus 50. So 50 is eliminated. How much time it takes? 1 hour. So we have intentionally taken 1 hour, so we need not divide. So rate of elimination is 50 per hour. Okay. So how much is rate of elimination here? Out of 50, 25 has gone. So 50 minus 25, that means 25 per hour. At this point, 25 minus 12.5. So it will be 12.5 per hour. At this point, 12.5 minus 6.25, it is 6.25 per hour. So what we note is, in first order kinetics, at high concentration, rate of elimination is high. At low concentration, rate of elimination is low. Or we can say, in first order kinetics, rate of elimination is directly proportional to plasma concentration. More the concentration, more the rate of elimination. Okay. Now we'll see the same thing in zero order. What is the rate of elimination at this point? 100 minus 80, that means 20 in 1 hour divided by 1. Here 80 minus 60, that is 20 per hour. 60 minus 40, 20 per hour. 40 minus 20, 20 per hour. So what we noted, whatever may be the plasma concentration, rate of elimination is same. So we can safely say in zero order kinetics, rate of elimination is independent of plasma concentration, or we can say it is constant. In first order kinetics, it is directly proportional. In zero order kinetics, it is constant. Now, have you ever heard what is 1 in first order kinetics? What is 0 in zero order kinetics? You must have heard about this name already, first order, zero order. Have you ever thought what is 1, what is 0? It is actually coming from a formula. Rate of elimination is directly proportional to which power of plasma concentration. If we place 1 here, it becomes first order. If we place 0 here, it becomes zero order. So in first order kinetics, R is proportional to plasma concentration power 1, or we can say directly proportional. In zero order kinetics, R is proportional to plasma concentration power 0. Anything power 0 is constant. So rate of elimination is constant. Now similarly, we have second order, third order kinetics also. In second order, rate of elimination will be proportional to square of plasma concentration. In third order, cube of plasma concentration. So these kinetics are followed by radioactive substances, and we do not use them as drugs. That's why in pharmacology, we mainly limit our discussion to first order and zero order kinetics. Okay, so this is first rate of elimination. Now moving to second thing, clearance. What was the formula of clearance? Yes, rate of elimination divided by plasma concentration. So we will calculate the clearance. Rate of elimination we have already calculated. Now if we divide it by corresponding plasma concentration, it becomes clearance. So plasma concentration here is 100, here is 50, here is 25, here is 12.5. So if we divide the two, 50 by 100 become 1 by 2, 25 by 50 become 1 by 2, 12.5 by 25 is also 1 by 2, and 6.25 by 12.5 is also 1 by 2. So what we note, whatever may be the plasma concentration, the clearance remains same. Or safely we can say in first order kinetics, clearance is constant. Clearance is constant in first order kinetics. Okay. Now we'll see the same thing in zero order. Rate of elimination we have already calculated. We will divide it by corresponding plasma concentration. It is 100 here. It is 80 here. It is 60 here. It is 40 here. So that will become clearance. So 20 by 100 means 0.20. You can write 0.20. 20 by 80 means 1 by 4. 1 by 4 means 0.25. 20 by 60 means 1 by 3. 1 by 3 means 0.33. 20 by 40 means 1 by 2 means 0.50. So if you note carefully, when plasma concentration is high, clearance is low. When plasma concentration is low, clearance is high. Or we can safely say in zero order kinetics, clearance is inversely proportional to plasma concentration. More plasma concentration, less clearance, less plasma concentration, more clearance. Okay, so that is important about clearance. Third, coming to half-life. What was half-life? It is the time in which plasma concentration become half. So if you see that we want to make plasma concentration half, how much time will be taken? So if we see the reaction here from 100, half of 100 is 50. So how much time it take from 100 to 50 will be half-life. And how much time it takes? 1 hour. So half-life here is 1 hour. Then half of 50 is 25. So how much time it take from 50 to 25? Again 1 hour. From 25 to 12.5, again 1 hour. 12.5 to 6.25, again 1 hour. So what we noted is half-life is constant in case of first order kinetics. This is logical also. We know that fraction is constant. So 50% will also be constant. So same time will be taken to make 50%, that means half. But on the other hand, in zero order kinetics, if you see, so half of 100 is 50. So 50 will be somewhere here between 60 and 40. So time taken from 100 to 50 will be half-life. So how much time is taken? 100 to 80, 1 hour. 80 to 60, 2 hours. And 60 to 50, half hour more. So it will become 2.5 hours. Okay. Similarly, the time taken from 80 to half of 80 is 40. So time taken from 80 to 40 is half-life. And how much time taken? 80 to 60, 1 hour. 60 to 40, 2 hours. So 2 hours. Okay. Then from 60, half is 30. So half-life from 60 to 30 will be 1 hour from 60 to 40, half from 40 to 30. So it will be 1.5 hour. And lastly, 40 to 20 takes only 1 hour. So what we noted, when plasma concentration is high, half-life is high. When plasma concentration is low, half-life is low. Or we can safely say in zero order kinetics, half-life is directly proportional to plasma concentration. Okay, so these are the main differences in the first order and zero order kinetics. First order, rate of elimination is proportional to plasma concentration. Zero order, it is constant. First order, clearance and half-life are constant. Whereas in zero order kinetics, clearance is inversely proportional and half-life is directly proportional to plasma concentration. Clear? Now you need to remember that almost 99.9% drugs, they follow first order kinetics. Very few drugs follow zero order kinetics, and you need to remember those drugs. So which drugs follow zero order kinetics? So you can remember them as 0 watt power. Just like we have 0 watt bulb at the home. So 0 watt power tells that these follow zero order kinetics. Zero means zero order kinetics. And the drugs are: W is warfarin, A is alcohol and aspirin, T is theophylline, T is tolbutamide, and P is phenytoin. So these are the important drugs which follow zero order kinetics: warfarin, alcohol and aspirin, theophylline, tolbutamide, and phenytoin. Okay. Now the most important question is, why some drugs follow first order kinetics and some drugs follow zero order kinetics? On which factor it depends? And second more important question, why we want to know what is the clinical importance, what difference does it make whether a drug follow first order or zero order kinetics? So we will discuss these one by one, starting with the first thing, why some drugs follow first order and why some drugs follow zero order. So for that, we will try to understand, suppose this is a drug and it will be metabolized by some enzyme in the body. Normally, for most of the drugs, we have surplus enzymes. Like we are giving a drug in a dose of 100, 200, 500 molecules, but the enzymes in the body are already 1 lakh. Okay. Now, suppose we give 100 molecules of a drug from outside. So, all 1 lakh enzyme need not work. So, out of 1 lakh, only 100 enzyme will attack the drug. Suppose they break 50% of the drug in 1 hour. In 1 hour, 50% of the drug is metabolized. Okay. Now, if we increase the dose from outside from 100, instead of 100, we give 500. Then instead of 100 enzymes, 500 enzymes will attack. So, because same number of enzymes are attacking as the number of drug molecules, they can break the same percentage in same time. So, that means again they can make the drug half in 1 hour. If we give 5,000 molecules from outside, so all from here 5,000 will attack. Again, they can break the drug into half in 1 hour. If we give 50,000, so 50,000 enzymes will attack. They can again break the drug to half in same time. So what is happening? What is happening is the percentage is constant. Same percentage can be broken in same time. So which kinetic it is following? Yes, first order. Now suppose we give 1 lakh drug molecules from outside. So all 1 lakh enzyme will attack, but still they can break the same percentage in same time. So it is following first order kinetics. But suppose we increase the dose further, like we make it 2 lakh, 3 lakh, 5 lakh, 10 lakh. But now the enzymes are 1 lakh only. So 1 lakh enzyme can break maximum 1 lakh. They cannot break more than that. So whether we give 2 lakh, 3 lakh, 5 lakh, 10 lakh, so now they can break maximum 1 lakh. That means now amount become constant. Okay? So that means which kinetic? Zero order kinetics. Okay? So you understand? Till the time number of drug molecules are less than number of enzymes. So enzymes will keep on attacking. So the drug follow first order kinetics. But when the enzyme become the limiting factor, number of drug molecules are too many. So now the amount become constant. So the drug start following zero order kinetics. So zero order kinetic will be followed when the enzyme become the limiting factor. So enzyme become limiting factor means enzyme becomes saturated. So zero order kinetics also known as saturable kinetics. Zero order kinetics or saturation kinetics are same thing because enzymes have become saturated. Okay, so till the time number of drug molecules are less than number of enzymes, it is first order. When the number of enzyme become the limiting factor, it is zero order. Clear? Now this is very well exemplified by a drug called aspirin. If you know aspirin, aspirin has 4 important indications. They are dose dependent indications. At the lowest dose, aspirin is used as antiplatelet drug. When we slightly increase the dose, it is used to reduce fever, antipyretic. At slightly more dose, it is used to reduce pain. And at high dose, it is used to decrease inflammation. So 4 indications of aspirin which are dose dependent. Hypothetically assuming for antiplatelet action we require 100 molecules. For antipyretic action we require 200 molecules. For pain we require 500 molecules, and for inflammation we require 2000 molecules. This is just an example. And for aspirin we have 1000 enzymes in the body. So if we use aspirin as antiplatelet drug, which kinetic it will follow? Remember, the number of drugs are less than enzymes, so it will follow first order kinetics. If we give it as antipyretic, which kinetic? Still first order, because enzymes are more. Analgesic, again first order. But when we use it as anti-inflammatory drug, the enzyme becomes saturated. So at anti-inflammatory doses, aspirin follow the zero order kinetics. Clear? So aspirin follows zero order kinetic only at high doses, not at low doses. Only at anti-inflammatory doses. So we have given 2000 molecules of aspirin. Enzymes are 1000, so it will follow zero order kinetic. But after some time, aspirin will be metabolized. So from 2000, it become 1500, 1200, 1000, 900. Now, whenever it become less than 1000, the enzymes are not saturated now. So it will start following first order kinetic. So any drug which follows zero order kinetic, whenever it become less than a particular concentration, it will start following the first order kinetics. So there is no absolute zero order kinetics. All drugs following zero order kinetics, they will change to first order at low concentrations. So that's why zero order kinetics are sometimes known as pseudo zero order kinetics. So do not get confused between pseudo zero order. It is same thing, because the drug is never following always zero order only. Clear? Now moving to the last question, why? Why we want to know whether the drug follows first order or zero order kinetics. So we can take the example of two drugs, one following first order, second following zero order. Suppose both are given required in 100 molecules. 100 molecules are required. Okay, and both become 100 to 50 in 1 hour. But the difference is in first order kinetics, 100 to 50 means half. So this is the half life. So every 1 hour it will become half. Whereas in zero order kinetic, every 1 hour 50 molecule will be eliminated. So that is the basic difference. Now suppose accidentally we have given overdose. Suppose we have given 800 molecules of a drug following first order kinetic. So if we have given 800, in 1 hour it will become 400. In second hour it will become 200. And in third hour it will become 100. So that means within few time, within 2-3 hours, it will become non-toxic. But on the other hand, if this drug follows and is given in overdose, drug following zero order kinetic is given in overdose, 800 molecules are given, in 1 hour how much will be eliminated? 50 only. So in 1 hour it will become 750. Next hour 700, then 650, then 600, 550. So it will take very long time to come back to non-toxic level. So that means if a drug follows zero order kinetics and we give an overdose, it will be very difficult to manage the toxicity. So any drug which follows zero order kinetics, we should give very carefully. There is very difficult for management of toxicity, because the plasma concentration will gradually, slowly decrease only. Whereas the drugs which follow first order kinetic, their concentration can fall quickly, because at high dose, the plasma concentration will be eliminated quickly. Clear? So that's why we remember the first order and zero order kinetics. So with that, we completed the pharmacokinetics. Okay. So quickly we can discuss the take home points we want to take from this lecture. So you need to know particularly the formula of clearance. Clearance is rate of elimination divided by plasma concentration. Also it is extraction ratio multiplied by blood flow to that organ. Then apart from the clearance, you also need to know the important formula of half-life, 0.693 by K or 0.693 into Vd upon clearance. Then we discuss the steady state, which is very important. 3 important factors in steady state, on which when it will be attained depends upon half-life, and how much will be attained depends upon dosing rate. And third important thing is what will be the variation at steady state. It will be dependent upon the frequency of administration. Okay. And then we discuss the concept of therapeutic drug monitoring. You need to know when we will do TDM, which drugs have narrow therapeutic index, when we will not do TDM. that we have already discussed. And lastly, you need to know the basic differences between first and zero order kinetics, and particularly the drugs following zero order kinetics. Okay, so lastly we can discuss some of the questions. Easy questions. Elimination rate constant of a drug is 0.05 per hour. What is its half life? So we discussed half life is 0.693 by k, so that will be 0.693 by 0.05. So you can see that 70 by 5, you can nearly 14 hours, near about 14 hours, not exact, slightly lesser. So answer will be 13.9 hours. Okay. Second question, which of the following follows zero order kinetics? The answer is phenytoin. This we all know, 0 watt power. So thank you very much.